Then I went on to talk about roflumilast and tapinarof. So roflumilast, the data had been presented in terms of efficacy and safety in patients 6 years of age and older. Recently, data was presented in a study conducted in a younger population. So very often, as we know in dermatology, we start by studying adults or older children, and then we go down up to the age where you do see the disease. So the study that was conducted in patients between 2 and 6 showed that the efficacy and safety was very similar to what has been done and conducted and published in adults and adolescents. In fact, when you look at the delta, so the difference between the active group and the placebo group in terms of efficacy, the delta is higher in younger children. This is something that we have seen in the past with other medications as well. So one thing that is interesting about roflumilast is that among the 3 newest agents, topical agents for atopic dermatitis, is the only one that has been studied in patients with body surface area up to 100%. So patients that you would think would be more amenable to systemic therapy were enrolled in these studies. The ruxolitinib study, the cap was at 20%. The tapinarof study, the cap was at 35%, although there was a possibility to enroll higher BSA patients in an open label study. But we will get, it has not been presented yet, but we will get with roflumilast data in terms of safety, but specifically efficacy for patients with very high BSA comparing active to placebo. I finally talked about tapinarof. So tapinarof is an AHR agonist. Like roflumilast is currently on the market for psoriasis, but not approved for atopic dermatitis. Something I didn't mention that is also important for people to realize is that with roflumilast, the product that is currently FDA approved on the market is 0.3%, but the studies in atopic dermatitis were conducted with 0.15. So if physicians are using right now roflumilast off-label for atopic dermatitis, they're using double concentration as compared to what has been studied. It's not the case for tapinarof. It's the same concentration, but still it has not yet been approved for atopic dermatitis. So the tapinarof phase 3 studies have been presented. The efficacy is very high. In terms of design, so the design of the tapinarof study, the difference between the tapinarof study and the other studies is that mild patients were excluded, so milds were excluded, but moderate and severe were included. All the other 3 drugs I talked about so far, the studies were only conducted in mild to moderate. Tapinarof, they included severe patients, so only moderate to severe patients, and at the time of primary endpoint, 8 weeks, up to about 45% of patients had reached a IgE of 0.1. So the efficacy, even in a more severe patient population, is very good. In terms of safety profile, it was fairly well tolerated. There were follicular events and headaches which have been associated with the tapinarof in the psoriasis program as well. These are usually mild and rarely will require patients to stop medication. So finally, something I talked about that is very exciting with the tapinarof, for which we have very good data for psoriasis. We don't have yet the data for atopic dermatitis, is that in the psoriasis population, when you treat patients with tapinarof and you clear them, if you bring them to normal skin, when you stop the tapinarof, it takes on average 3 months for the disease to come back with a physician global assessment of mild. And what that means in practice, when you participated in the clinical trials like I did, is that you may take a patient with 10% body surface area covered with psoriasis, you bring them down to 0, then 3 months later, they're back to mild, but in terms of plaque severity, not of body surface area. Very often it's only 1 or 2 lesions here and there that can be treated with topical therapy. So it remains to be seen if the same type of effect will be observed in atopic dermatitis. The studies have been conducted, the phase 3 program has been conducted to test that, but it has not yet been presented. It will be presented soon.
Well, I mean, I could ask you more about it, but I think you summarized it pretty well, so I might just call it there. But thank you.
Good. No, I think it went well. I didn't say anything bad, like sometimes I said a few times.